Hey there. Guess what time it is? 4 o'clock in the mountains, which means 6 o'clock on the East Coast. And it's Tuesday evening. There is only one place that you are supposed to be, and that is right here. Fertility with Fink and Friends. I am Fink, and you are friends. And as we do every Tuesday evening, it is great to be with you here after a wonderful holiday weekend. I hope yours was as stupendous as mine. It was good to have a little break. I was very honored to have a colleague by the name of Dr. McNichol, who was here in the office covering for me this weekend. So I got to have a couple of days off, which was, oh gosh, so nice. But I knew that I would be coming back on a Tuesday, and oftentimes, when you come back when you have Monday off and then you come back on Tuesday, it's almost like insult to injury, that Tuesday just becomes your Monday, and it's abusive either way. But it was really very special to come back today, knowing that I got to spend my afternoon here with all my friends. So thank you so much for being here. We've got Facebook, YouTube, and LinkedIn right here in the middle. We've got CNY's Instagram here, and I am Randy Fink MD on my Instagram right over here. So nice to see everyone. Let's see who is joining us. Hi, Shida. Nice to see you, and a very special hello to the Bama gal and man. That would be my beautiful mother and father in Mobile, Alabama. Thank you very much for being here this afternoon. Hi to RPL Mama. Kaylin, nice to see you. Desanya, it looks like, Barbara BJ Ladybug is here from Miami. Thank you for being here this afternoon. A special hello to Sydney from our embryology lab, and to Jenny. You are number one on my Instagram feed today. Thank you for joining me right at the top of the hour. Over here on the Instagram side, let's see, Butch's Barbecue looks like was the first to join. You got my interest there. I just tried to make a brisket this weekend, and once again failed miserably on the smoker. It's I'm getting to the point where, even though I love using that smoker, I'm thinking that it might just be easier to go to Dickey's Barbecue and get buy brisket next time than try to make it on my own thing. Mel Touchstone, hi to Witchy Bliss. Nice to see you, Ashley. Let's see, what do we have there? Salvarez, Rosa SD, hello as always. Ashlyn, Bits of Lovely, hi Tanya, thank you for being here this afternoon. And Laura and Yummy Sam, the Meg Johnson says, just had an ectopic pregnancy removed by a surgery. How long should I wait to do my FET? Well, so if you have a tubal pregnancy and you have surgery to remove that, even though the pregnancy itself is coming out and there will be pathology to confirm that, you want your hormone levels to really restore themselves back to normal, and all the inflammation that went into that pregnancy to kind of be able to resolve itself. So my recommendation is that you skip a cycle, that you'll get a period after having the ectopic surgery, and then you have one nice normal period, nice normal cycle, and then by the time you reach that very next cycle, you should be okay to proceed with another embryo transfer. Looks like Black Artemis, Ryan Kelly, Rain Kelly, forgive me. Hi, Sharmila. Nice to see you today. Journey to Baby W. I've got Ashlyn asking, I had my egg retrieval today at Syracuse, and everyone was so lovely. We're so glad to hear that. 21 eggs retrieved, praying for fertilization. Thank you, CNY. You're amazing and have been this entire journey. We love to hear that kind of feedback. Ashlyn, thank you so much. Lucky me again, Bits of Lovely. Will CNY prescribe metformin for PCOS IVF patients? So yes is the answer. Metformin is a medication that is commonly used. It is intended for use for people with diabetes. So even if you have no diabetes, what we know is that when your AMH level is on the higher side, as it is with polycystic ovarian syndrome, or if it's on the lower side, as it is with a diminished ovarian reserve, Metformin can be very helpful with egg quality. In the case of PCOS, what's happening is that those eggs are all growing in a very high estrogen environment. So we can improve that. We can bring down some of that estrogen and really help with the egg quality by using metformin. So bits of lovely, yes, I would say I would indeed. Rosa SD. Do you recommend removing an endometrioma, 4.7 centimeters? Let's see, endometrioma, no pain. Surgeon says it's in a position unlikely to torse or to twist. Before FET, do you recommend removing it or suppressing it with Orilissa? Well, so if we give you medicated suppression for endometriosis, Rosa, what we're really trying to do is to turn down the way endometriosis talks between the brain and the uterine lining. We're trying to suppress an inflammatory protein in the uterine lining known as BCL6. So by taking suppression, you're not going to really do anything to treat that endometrioma in terms of its size. In 60 days of treatment, that's not going to change anything. I would say that, hey, look, if you don't have pain from it, if it's really just an incidental finding, the surgeon believes it's probably stuck down and it's not likely to twist or torse on itself, then I think you're probably okay to just suppress that with medication for 60 days. I would expect the outcomes to be similar. Now, certainly taking an endometrioma out of an ovary will decrease your ovarian reserve. So that means that your AMH level will go down. As long as we're done retrieving eggs, I'd say you certainly can remove it if you want, but I would say that you do just as well, likely using suppression before your transfer. Sharmila says, I'm mid-cycle. Hope my retrieval will be on Monday. Hope you do my retrieval on Monday. I will be here. Awesome. R. Alvarez, nice to see you today. RJC says, I'm so scared. I'll be scheduling soon, but scared. Hey, listen, you know what? If you weren't scared through this process, I would say, what's wrong with you? Because you know what, you don't do this every day. This whole thing, there's a big mystery to it. And even if you've done IVF several times and you know the process and you know what the medications feel like and you know how this whole thing goes, there's always a mystery about what's going to happen at the end. Are you going to get eggs, and are those eggs going to make embryos? And if so, how many embryos? And what's going to happen with them? Are they going to grow? Will they make blast? Are we going to PGT test? Is it going to turn out, what's going to happen? These are all questions that we have every day going through this process. So if you weren't nervous about that, RGC, I would say something's wrong. So quite okay to be nervous, but fortunately we do this every day. So lean on us, rely on us, and rely on your friends right here on Fink and Friends who have been through this process. Marielle says, began my first round of stims in Sarasota. Fantastic. Let's see. Lindsay Holter says, hoping to transfer in October. October is the month of my birth. So I think that is a perfect time for people to get pregnant. What do you think about that? Can a mature egg not fertilized with a sperm prep and ICSI? Yes, absolutely. Because the process of an egg maturing is related to many factors, or rather with an egg fertilizing is related to many factors. It has to do with the sperm. Is the sperm able to fertilize the egg? But in addition to the fact that the egg is mature, meaning to say that we can look at it under the microscope and see that it is indeed a biologically mature egg, we still don't know anything about what's going on with the DNA inside that egg. And if we don't know what's happening with the DNA, if that DNA is faulty and a sperm tries to fertilize it, it may create an embryo, but the embryo will not continue to grow, or it might just not fertilize on its own. So, yep, absolutely, that can happen there. Lucky Me again says, my husband and I just recently did a transfer in Sarasota, And it worked. Well, that is fantastic. Love to hear that. Elisita says, thank you for answering my question last week. My pleasure. I had an embryo transfer last week and a beta tomorrow. An at-home test is positive, and I hope it's not a fluke. What is a good beta to expect, or what is next? Excuse me. So the first thing that I want to warn you about is are you on an HCG booster? So what are the HCG boosters? If you're doing a natural cycle, an HCG booster is metabolized in your body as a little extra progesterone, and that helps you. If you're doing a medicated cycle, HCG boosters really don't do very much. But HCG booster is where you take a little bit of the pregnancy hormone, 250 micrograms, and you inject it subcutaneously every day. And that is what an HCG booster is. Again, in a medicated cycle, really not a lot of evidence that it helps. In a natural cycle, it absolutely does. Why doesn't it help in a medicated cycle? Well, because again, it's becoming progesterone. In that medicated cycle, we're giving you progesterone in oil, right? So you're getting so much progesterone that the little bit that you get from converting HCG to progesterone is nominal and doesn't make much difference. But if you're in that natural cycle and you're using the HCG booster, and we go to do a pregnancy test, what do you suppose that pregnancy test is going to show us? Well, you're putting HCG in your body. And what are we testing from the blood? HCG. So that first pregnancy test is going to be positive. What you have to know is that's not a failure. It's not an accident. It's not a mistake. We're putting HCG in your body. So the first one is going to be positive. It's the second one that's going to show us about the true positive of your pregnancy test. So Elisita, I would say if you're getting a positive pregnancy test at this point, I'd say you're likely to be positive there. So that is awesome. Congratulations. Okay, let's see who's over here on my Instagram. Shada asks, could you please discuss uterine microbiome and how we know if there's any hidden uterine lining infection? Well, you can test for that, Shada. And the test, well, so there's two different ways to do that. You can test from the just a simple endometrial biopsy. And the endometrial biopsy will show us if there is an overgrowth of plasma cells. Plasma cells are the immune cell marker that shows chronic inflammation. And that's what we know of as chronic endometritis. Shada, I can't remember if we did an endometrial biopsy in you. At the moment, I'm just kind of blanking. But that is how you do it. It can also be done with a proprietary test known as an EMA and an ALICE, where it's testing for some specific things. In my opinion, I don't know that there is excess value to doing the EMA and the ALICE when insurance will cover a regular endometrial biopsy that can look for the presence of plasma cells. There's a specific marker for plasma cells. It's called CD138, and we can specifically ask for CD138 to be tested, and that goes through LabCorp or wherever your insurance says to go, and is generally a covered test. So now the presumption is that people do not have endometritis. Endometritis is something that can prevent people from getting pregnant, and so usually we see it not so much in the general infertility population, but in people who have had recurrent implantation failure. If there is an ability to do an endometrial biopsy, I would encourage it because, it's not very comfortable, but it's nice to be able to do under some anesthesia. That's also what they call an endometrial scratch. And even though the evidence hasn't shown us that an endometrial scratch is necessarily beneficial in the general population, it can create an immune response in your body that ultimately results in improving chances of implantation in some circumstances. Brittany, I'm sorry, Brittanilli, Brittany Lynn. Okay, yeah, I can read. I typically ovulate about cycle day 20-ish. Just finished my last dose of letrozole. When should I expect to ovulate? During my first medicated cycle, with timed intercourse since the hysteroscopy and laparoscopy. Well, so when you use ovulation induction like letrozole, it typically causes you to ovulate earlier than you would in a natural cycle. So usually the what you're doing there is you're stimulating more FSH, follicle stimulating hormone, from your pituitary gland, which is causing the follicles in the ovary to grow, eggs being inside them. So now with letrozole, some people do actually, even with Clomid, some people do ovulate a little bit later. It is not always predictable that it's going to be on cycle day 14. So there are times that we'll give people letrozole with timed intercourse, and then at the expected time that we should see a follicle starting to grow, just really not much there. But then if we look a week later, we may find that, oh, lo and behold, there's your follicle. Just something about you tends to grow those follicles a little later than usual. But in most cases, people will grow them a little more predictably, a little earlier than you normally would if you typically ovulate on around cycle day 20, because most people will ovulate on around cycle day 14. So, good luck with that there, my friend. How many embryos is enough to bank for securing two babies? Well, if we're looking for babies here, it depends on whether we have tested embryos or untested embryos. So, usually we say a tested blastocyst, so you've had PGT testing. We generally like you to have two. We expect that after two embryos, or two embryo transfers, you'll have about an 88, close to a 90% probability of pregnancy. So two would be the number that I would suggest for a tested embryo. If they are untested blastocysts, well, it really kind of depends on your age, but in general, I would say about four embryos is what we would expect. So if you have untested blasts and you did two embryo transfers and you didn't get pregnant, I wouldn't say that anything is wrong at that point. You're not quite behind the eight ball yet. I would say you keep doing transfers. It doesn't mean you have to do more stuff to find out what's wrong with you, because you're still kind of within the boundaries of what we expect from those kinds of statistics. Hello to Staley in Miami. Thank you for being with me this afternoon. Maria, Georgia. Christina asked, do you recommend people with endometriosis grow their embryos to day 5 and test them, because you only get two transfers per 2 months of suppression? Or do you recommend day 3 embryo transfers? Well, Christina, I'm not sure that's really not true that you only get two transfers for 2 months of suppression. When we suppress endometriosis before doing embryo transfers, the goal is to turn down the inflammatory marker in the uterine lining. But that effect should last for longer than 2 months. Exactly how long it lasts is unclear, but I would expect at least that to last for about 6 months. I would expect probably a minimum of 6 months, and I've seen some studies that even show, up to 9 months to a year. So, the decision to use a blastocyst versus a day 3 embryo is kind of really a decision that's based on a bunch of things. One is that we know with a blastocyst or a day 5 embryo, there's a higher probability of that embryo being able to get you pregnant. Whereas a day 3 embryo, we don't know if that embryo is going to continue to grow or not. So our feeling is, well, if you're limited in the number of embryos, better to take that embryo and put it inside of you. Because if we put it inside of you, inside its mom, maybe it has the ability to grow or to repair itself if it's abnormal inside of mom, as opposed to dying off inside the laboratory. So that's our feeling. If we're limited in numbers, we're going to say do a day 3 embryo transfer. A blastocyst is always going to get you a higher pregnancy rate. So if you can grow to blast, it will ultimately mean fewer unsuccessful transfers. if that makes sense. Let's see who we got over here on the Facebook side. I see Callie and Mandy and Lindsay and Caitlin. I see Johanna, I believe that says, Jeanette. Caitlin says, what is a blast? And that's a good question because I keep using the term. So, what exactly does that mean? What is a blast? A blast is a blastocyst, and a blastocyst is a day. Let me fix my light over here. A blastocyst is typically a day 5 embryo. It's day 5, day 6, potentially even day 7. When an embryo is growing, it starts out in what is called a cleavage stage embryo. So sperm comes together with egg, and then it starts to divide and make a bunch of little cells. By the time it's at day 3, what it's really trying to do is that it's still trying to figure out how to keep dividing and keep growing. From that point, it continues to grow. It grows into what's known as a morula, and then the next step is what's called a blastocyst, and that's typically begins on or about day 5. Now, some embryos grow a little bit more slowly, and that's okay too. Day 5 and day 6 embryos typically will respond in the same rate. They have a very similar pregnancy rate. Day 7 embryos typically don't respond as well and have a lower chance of getting you pregnant, but they're still good embryos because I can introduce you into 1,000 babies I know that came from day 7 embryos. But that blastocyst, the reason that it is considered a stronger embryo is because once it reaches that stage, I always like to think of it as it's a little functioning factory. It's already a little metabolic machine that's doing things. It's growing, it's producing energy. It's got a million little biochemical reactions taking place. And so once it reaches that point, we know it has a higher chance of surviving. And that's why a blast or a blastocyst is considered to be a stronger embryo. So thank you for asking that question. It was kind of an important thing. If I keep talking about a blast, we're having a blast here. Not the same thing as having a blastocyst. All right, so let's see back up at the top. Kelly says, you did my transfer on August the 20th and we're pregnant. Hot dog. Hoping to keep the positive vibes, and thank you for your positive, kind words on transfer day. Oh gosh, that makes me so happy, Kaylee. Thank you very, very much. Mandy says, if using Provera during stims, what cycle day do you need to start by? Also, can it be taken at night? Prometrium makes me dizzy in the past, so I'm worried about taking Prometrium in the morning on work days. Okay, yeah, so Provera we use as an antagonist, which means that it stops you from ovulating. So if we're giving you all this medication to rev up the ovaries, right? If we're revving up your ovaries, we don't want those eggs reaching a point where your body wants to release them before we're ready for them, because in IVF, we're coming for those eggs. We want those eggs. We don't want them to disappear into your belly someplace. So that's why we use a medication called an antagonist, which can either be an injectable medication, usually Cetrotide or Ganirelix, or we use Provera. Provera is a great medication. It's a pill. It's dirt cheap. It's about $3 for a bottle of 30 of them. And you find me anything in the IVF world that's that cheap. I mean, that's a good thing. And it's one less shot to take because, I mean, it almost gets, punitive to have to get so many shots. So certainly if we can do that, it's my preference. I think it actually works a little better in many cases than does the injectable, the Cetrotide or the Ganirelix. So I prefer it. The problem with Provera is that it is progesterone. And if you're putting progesterone onto your uterine lining, it means that you cannot do a fresh embryo transfer. It means you have to freeze your embryos or do PGD testing if that's your, you freeze them anyway. But no fresh transfer with Provera. Otherwise, it is my preference, and I recommend it really for everyone. You can start it. Usually, we start it by day one of stim. It can also be started by the first day of the menstrual cycle. So, like day one of flow. That's how I used to use it, Mandy. And now I just find it's easier for folks to start everything at the same time on day one of the stimulation for IVF. Because if you wait a little longer, then you run the risk that you're going to get some follicular growth that can't be stopped, that you're going to start some portion of the cascade moving that's eventually going to make a follicle ovulate when we don't want it to. So starting on stim day one is the latest really you should be starting your Provera. Provera is much more potent as a what's called a progestogen, a type of progesterone, than is prometrium. Prometrium is natural progesterone. It's called oral micronized progesterone, and it is similar to a natural progesterone. And natural progesterone makes people sleepy, and that's why you take it at night. Provera doesn't do that. Provera does not make you sleepy, or it should not make you sleepy. So it really can be taken at any time during the day. I usually recommend that you take it in the morning because your last dose of Provera, if you're using it as an antagonist in an IVF cycle, is going to be on the morning of your trigger. But if you're more comfortable taking it at night, I don't see any problem with that. But just understand it's the natural progesterone in prometrium that makes you sleepy. It has a sedative effect. Provera should not. Now, somebody's going to be out there going to say, "Well, it made me sleepy." Well, I suppose anything can, but its metabolite is such that it doesn't activate the same pathways as the natural progesterone does. And that's kind of how that works. Lindsay says transferred on July 8th, but we're currently almost 11 weeks pregnant. Wanted to thank you in the Colorado office. Oh my gosh, that is great news, Lindsay. Thank you so much for sharing. That is fabulous. What causes the thyroid level to go up? Coming from Caitlin here, I would like you to call me. Okay. Well, we usually make an appointment there. You missed Friday. I was not here Friday, so I'm not sure what that's all about there. Thyroid is the gland that lives in your neck here, and the thyroid is something that can really go awry. It's a part of our body that is just not perfect, and so hypothyroidism, when the thyroid function goes down, the thyroid level, the TSH, the thyroid stimulating hormone, goes up. So we're looking for that TSH number to be optimized for fertility to be between a 0.5 and a 2.5. So let's just say, hypothetically, your thyroid TSH level is 3.5. Well, I would look at that and I'd say, for fertility, I want you to I want you to bring that number down. So we are going to treat that thyroid level. We're going to give you a little bit of thyroid to try to bring it down, because when we give you more thyroid, the higher the function of your thyroid, the lower the TSH goes, right? The lower the function of the thyroid, the higher the TSH goes. So it's opposite there. So we're looking between 0.5 and 2.5. Hormones can also affect that TSH, but it is one of the more common endocrine problems that we as humans have. Endocrines, the endocrine system is the hormone system in our body. The thyroid controls our body's metabolism. And since we are just not perfect creatures, thyroid is something that oftentimes does get messed up. One of the other things we like to check in the thyroid is what's known as an anti-thyroid antibody, which means that some people, and that you may have heard of, is called Hashimoto's disease. And that's an autoimmune thyroiditis. Autoimmune thyroiditis. In other words, your immune system attacks your body's thyroid gland. And that's one of the more common reasons that people end up becoming hypothyroid. In the process there, sometimes they can be high, sometimes they can be low, but autoimmune thyroiditis is a common cause of longstanding hypothyroidism. So we also check that too, because if you have a an autoimmune response against your own thyroid gland, it means that you've got an immune response against a lot of things, and that may be contributing to fertility problems there as well. Let's see. Shabnam says, hello, Dr. Fink. How long do you take Prograf after a positive pregnancy test? So Prograf, medication that we use to help prevent rejection of a pregnancy. And usually I recommend that you take that through the first trimester. If you have had recurrent pregnancy loss or other poor obstetric outcomes, like things like rupture of the membranes at 16 weeks or something like that, there may be a situation where we recommend that you take it a little bit longer, take it through the time that something bad happened to your pregnancy. But in the general population, I would say through 12 weeks. Let's see. Be kind, be love. Oh, what's a beautiful name. Thank you for having that handle. Can inflammation cause chromosomal abnormalities that end in miscarriage? Well, chromosome troubles with embryos typically begin at the level of the egg and the sperm. Now, you got to remember, and I've said this before, if you've heard me say it, please forgive me, but it's really an interesting fact. The sperm that comes from the male partner today was manufactured in his body 3 months ago. The egg in your ovaries has been there since before you were born. And so that gives it a lot of time to become less stable and for the DNA to start to decay. Now, what causes that DNA in particular to kind of start to fall apart? There are lots of different things. We just really sort of associate it with aging. But how do we as a body age? How does that happen? It absolutely happens because of inflammation. Inflammation is the source of cancer. Inflammation is the source of pretty much just about every disease that we know. Now, there are genetic diseases and all kinds of other things, but inflammation is when our body is creating some sort of damage to the cell membranes. And if they're damaging the cell membranes, then they are ultimately going to be damaging what's inside the cells as well. So, does inflammation cause a chromosomal abnormality? Well, not directly. So it's not like, oh, well, I fell and I hurt my knee and now it's all red. I can see that it's inflamed, or I'm feeling particularly achy today. I've got inflammation in my body. I think that's damaging my chromosomes. Not quite so directly, but indirectly. Be kind, be love. Yeah, you're right on the money there for sure. Georgia Fox says, what's the research and efficacy on rectal progesterone use versus vaginal? Well, so when we use vaginal progesterone in folks, we are doing that because it creates a local effect in the lining of the uterus. And as we're trying to, what's that progesterone do? It's compacting the uterine lining, and it's progestational, meaning to say it's pro-pregnancy. So in someone who is not pregnant, for instance, estrogen causes the lining of the uterus to grow, while progesterone causes the lining of the uterus to thin. So they're opposing effects there. They're kind of trying to balance each other out. But in pregnancy, progesterone is what maintains the uterine lining and its blood flow so that a pregnancy can grow inside of it. So when you use a medication rectally, you will absolutely absorb that medication because the vascular supply in the rectum is tremendous. It's an excellent way to get systemic therapy into the body. And so that's why we have things such as rectal suppositories. When we're really just trying to treat a local effect in the uterine lining, we're way better off in the vagina because the blood supply in the vagina is contiguous with the uterus, particularly in the upper 2/3 of the vagina, is contiguous really with the uterine vessels, and so we're really able to get that more directly into the uterine lining as opposed to rectally. Some of it will get there, but rectally is probably a more effective mechanism than, for instance, taking it orally. When we take things orally, let's say you take a progesterone pill, what happens? Well, it goes down your throat, right? We feel it going down there and it goes into your stomach. Your stomach is full of acid. And that acid is trying to break things down. It's trying to rip things apart. Very high acid environment. If you stuck your finger in that acid, it would burn your hand. If you've ever vomited, you know that a lot of times as that comes back up, it can burn you up in your throat here. Well, once things are broken down there, the blood supply in the stomach then goes right into our liver. The liver lives here in our right upper quadrant. And the liver's job is, its principal job is to detoxify things. And that's what's called the first pass effect. And that may be a term that you've heard of. The first pass effect means that when you take a medication, you have to have enough medication in that pill that you swallow to get to survive the stomach acid and to get through your liver, which tries to break it down and detoxify it so that there's still enough of it left over at the end of the day to do the job that you want for it to do. When you use a rectal suppository, it's going right into the system. It does not first go through the liver. That first pass effect is not there. However, most people are much more comfortable taking a pill than they are using a rectal suppository, right? Becca Ayer says second retrieval is set for Monday. My husband has had 2 semen analysis done last week, both showing 0 sperm. He has another semen analysis for Wednesday and Friday. If they find nothing, what would the next steps be? Well, Becca, so if you come for your egg retrieval and there is no sperm, and that can be for any reason. Let's say that, wow, he ended up getting called to work and he could not miss. He could not miss work, and so he can't even produce a specimen. Well, same situation, similar situation, I should say, as if he produces semen, but there's no sperm in it. Basically, what we do in that scenario is that we proceed with the retrieval. We retrieve your eggs and then we freeze them. Because when we freeze the eggs, we're going to get them, we're going to stop them in time, and then we can all take a breath and sort out this sperm issue. What happens next if he's not making sperm? We would send him to a male fertility specialist who can try to figure out where is the sperm, what's the problem here with the sperm. Oftentimes there are procedures that they can do to be able to get sperm directly from the testicle. And so that's kind of what they specialize in. And so eggs are frozen. We sort out the sperm problem later. We can always thaw the eggs and fertilize them later. So no, all is not lost. Don't worry. Now, it certainly would be easier for everybody if there happened to be sperm there. So if you'd like to have a serious chat with his testicles, then maybe, that may change things. But that's a frustrating problem. And it happens more often than you might believe. And that may be a situation where the male has had a semen analysis 2 or 3 years ago and opts not to repeat it and comes in for your retrieval day. And lo and behold, we find there's no sperm there. What's happened in the interim? Well, things happen. Again, our body obviously is not a perfect system. Hi to Brandis, our wonderful nurse practitioner. Thank you for being here this afternoon. Let's see. Stephanie Diana said you did my egg retrieval today. The best. Oh, thank you. Thank you so much. God bless. I can't wait to see you again for my transfer. Well, not as much as we can't wait to see you. And even more than that, we can't wait to see you pregnant. I am just hoping that this year will be a wonderful year for Christmas cards because we love, and it's not just my location here in Colorado. Um, Every doctor who's ever taken care of you loves to see your family. So if you are able to get pregnant, um, God bless you. And please show us your kids. Show them off. Be proud of them. And oh my heavens, we share in your delight because that's what we do for a living here. So anything you can do to help, we appreciate it. Oh my, Glenda says, I'm a travel patient. How would we know if we needed to do a fresh transfer or FET just to prepare how long we need to stay in Colorado? Well, so we know about, okay, so the first thing is fresh transfer is included in the price of transfer at CNY. My preference in general is to always do a frozen transfer if we can, because frozen transfers do have a higher success rate. However, fresh transfers we offer, and many people do get pregnant from fresh transfers. So it's not that they don't work. There may be a hormonal situation, Glenda, that tells us it's not a good idea. Um, and there's some complicated reasons for that, but the simplest way to think about it is that your body is in egg making mode. And when it's in egg making mode, it may not be ready to be in getting pregnant mode. And so we can sometimes tell that based on the number of follicles that you're growing in the ovaries, and certainly by the hormone levels. So we know that information just before your transfer. I'm sorry, just before your retrieval. If you're planning to stay for a fresh transfer, it's going to be anywhere from 3 to 5 days after. Our recommendation is that if there are 4 or fewer embryos, that you transfer on day 3. And if there are 5 or more embryos, that you transfer at day 5. And that's kind of the way that works. Let's see what else we got over on the CNY Instagram side. Ashley says, is the sonohystogram test recommended for every patient before starting treatments? I got an HSG done already, but was unfamiliar with the other. Yeah, so they are different tests. The HSG is a hysterosalpingogram, and its job is to show the contour of the uterus and let us take a look at the fallopian tube so that we can see whether your fallopian tubes are open or blocked. But what it doesn't do is that it doesn't show us fine detail inside the uterine cavity. And that's what a sonohysterogram is, also known as a saline sonogram. So, what we do in that scenario is that we would place a little catheter inside the cervix and place a teaspoon of fluid inside the cervix while doing a vaginal ultrasound, or we do it at the time of an HSG. Once the HSG is done, we just place the ultrasound probe inside, and the fluid is still in the uterus, and so we can see the contour of the uterus. I very, very, very strongly recommend that your uterine cavity specifically be evaluated before you do a treatment, because it is extremely common that we find something in the uterine cavity that's preventing you from getting pregnant, like a polyp. And there are plenty of folks who I have seen who have said, "No, we're not going to do that. We don't need that. We're gonna proceed. We just really want to get pregnant right now. We want to start right now." And they do 3, 4, 5 IUIs maybe, or they'll do IVF, and then they'll do an embryo transfer, or 2 or 3, and then they evaluate their uterine cavity when something's not working, and lo and behold, there's a big polyp, a fleshy growth that's sitting inside that cavity that could have been preventing you from getting pregnant all this time. So we just wasted a bunch of time. We just wasted a bunch of money. I think you're way better off actually having the uterine cavity evaluated specifically, because again, the HSG really doesn't show us the nuances of the uterine cavity. Does a larger size endometrium mean I need more doses of Orilissa for suppression before FET? No. The data shows that it's 2 months of suppression, no matter how much endometriosis you have, should shut down the marker, the BCL6 in the uterine lining, and return your odds of conception back to as though you had no endometriosis at all. Now, if you've got a pain syndrome, and Rosa, I know you don't, but if you've got pain from your endometriosis, then that's a situation where you really got to think about surgery, because we can do a lot more than just suppress endometriosis. We can make you feel better. But without pain, I think 2 months of suppression really should be fine. Larger endometrioma does not mean more suppression is necessary. Let's see here. Sharmila asks, I'm on Omnitrope since 1 month now, and I'm on my stims for egg retrieval. I think it'll be on Monday. I finished the Omnitrope. Do you want me to continue or stop? Well, I like Omnitrope to continue if you can, really through the trigger date. Now, if you are thinking that it's just, gosh, it's only going to be a couple more days before you were going to trigger anyway, then I think it's fine to go ahead and stop. I think you got the benefit from it. Is it worth spending all that money to get another vial of Omnitrope to take for 2 more days? Probably not. Okay. R. Alvarez, Thursday embryo transfer in Sarasota. So excited, not sure to add intralipids. I had an HCG wash today and I got a brownish discharge. Well, yeah, because what goes in must come out. And so it mixes up with all that stuff in there. And remember that lining, it's a bloody lining. That lining has a blood supply. So you put it in, it swishes around. And so, yep, it's going to come out. I do think lipids are a good thing, specifically lipids. It's an IV dose really of the keto diet, but it also specifically treats things like natural killer cells, which may be something that we don't do very well in testing for. So if you're able to do lipids, I would say certainly at least that one infusion. And in folks who've had recurrent losses, I do recommend the weekly lipid infusion. My DIVF journey, thoughts on shipping embryos and risks. Well, by and large, shipping embryos is a pretty safe thing to do. Now, if you could avoid shipping embryos, are you better off? Well, there's a cost associated with shipping, embryos, because they go in this little thing. It looks like an R2D2 unit, and I'm always say when I see the embryologist with it, I says, "That's your R2." It looks like a little robot device, but that it keeps things frozen, and it will keep those embryos frozen for up to 30 days. So even if FedEx has a storm in Memphis and your embryos get stuck on the ramp overnight, doesn't matter. They are well insulated there and well prevented from thawing. The issue really comes from when they are taken out of their cryopreservation tank and put into the transfer tank. And then when they're taken out of the transfer tank and put into their cryo tank in their new location. That's really where the risk is. Now, most embryologists are pretty good at doing this. And so that time being out of cryo is minimized, but the longer it's out, potentially the worse off it is. And so are there risks? Theoretically, yes, absolutely there are risks. But is it pretty safe to ship embryos? Yes, it is. Michelle Marks says, can I take all of your recommended supplements while suppressing, for endometrial, for transfer while suppressing with Oralissa? Yes, the 5 supplements that are part of the evidence-based protocol for embryo transfer, your prenatal, CoQ10, vitamin D, vitamin E, and L-arginine. 4 out of those 5 things are on the protocol for egg quality. L-arginine is not on the protocol for egg quality. Please don't use L-arginine for egg quality. And just note that the dose of vitamin E is a little higher in those for embryo transfer. If you have seen my little ebook, which is called The Vitamin Victory, outlines it for you, gives you a little discount if you want to buy a bunch of handful of supplements. You can get that by seeing my link tree, which is linktr.ee/Randy Fink MD. That's my link tree. Or just look at my Instagram, which is Randy Fink MD. And it's that link is in the bio there. It's called The Vitamin Victory, $7 ebook. I think it's well worth it because it'll get you about close to $18, I think, in discounts on the supplements. And it outlines everything that you need to know about evidence-based protocols for what should this handful of vitamins be that I need to take. Let's see. So yes, you can take them while you are suppressing for endometriosis. Is it recommended to do intralipids after treating endometriosis 3 months with Orilissa? I would say yes. I recommend lipids really for everybody who's going to have a transfer, as long as it's easy enough for you to do. Second retrieval set for Monday. My husband has had, I think we just talked about that. What would be the next step be if there was no sperm, was the question. Let's see, going back to the Facebook side here. Do you recommend transferring an abnormal with a mosaic? They are our last 2 embryos. What about boosters? And this comes from Johanna. Well, so an abnormal or a PGT tested aneuploid embryo means it's an abnormal embryo, has a very low but not 0% chance of getting you pregnant. It's on the order of about 5% because that PGT testing is not a perfect system. Whereas the mosaic embryo has a reasonably high probability of getting you pregnant. And assuming that embryo sticks, it gives you really just as much chance of having a normal baby as does your euploid embryo. So can you transfer an abnormal with a mosaic? Yes, you can. Is there some theoretical risk that the abnormal embryo is going to somehow pull down or make bad the potentially good embryo that is your mosaic? People talk about that, but I haven't seen good evidence to show that that's the case. Now, I would not be comfortable telling you, hey, you should transfer your aneuploid embryos with your euploid embryos. Why not? Well, because that euploid embryo, man, is like, bro, that's the cream of the crop. That's the one that we're ultimately looking for through this whole process. So I wouldn't risk it with a fully euploid embryo, but with the mosaic, if you wanted to transfer an abnormal embryo, yes, you could. What's the probability of having a second ectopic pregnancy with IVF? And that comes from Jeanette. So the risk of ectopic with an IVF pregnancy is on the order of about 1%. So it's 1 to 2%. It's pretty low, but it can happen. It's a higher risk, incidentally, in transferring day 3 embryos than it is in transferring blastocysts. Why is that? Well, because a day 3 embryo in nature, if that little sperm met that little egg, bing, and it happened in the fallopian tube, the day 3, which is how it happens in nature, that day 3 embryo would still be, by day 3, would still be in the fallopian tube trying to work its way down into the uterus. So there may be something that we call a chemotactic factor, which means something that's attractive in the chemistry, something that's pulling that embryo up into the tube. So a day 3 embryo has a higher probability. If you had one natural ectopic and then you went to get pregnant again, the incidence of having another ectopic is unfortunately very high. And that's because we know that you've got damaged tubes. But with IVF, fortunately, the overall risk for an ectopic is very low. So the odds of it happening again are also very low. All right. Let's see, how soon after a polyp removal can I get started with a frozen transfer? And that comes from Carolyn. Really, the very next cycle, Carolyn, you can jump right into it. You do maybe that polypectomy in the beginning of your cycle, go on, have your next period, and you can go into your transfer cycle the next one. Tiffany says, I'm waiting for my cycle day one to do my first egg retrieval, but I have PCOS. I haven't missed a period in 2 years, and now I'm at cycle day 36 of course, it's because the watched pot never boils, right? I put a message in the portal. What should I do? My urine HCG was negative today. Usually, what we'll do, Tiffany, if you're a travel patient, typically what we'll do is we'll have you just go ahead and do a baseline, and we'll see what your lining looks like. Because if you haven't, it may be that you just ovulated late, and we're going to look and see, and it's going to look like, oh gosh, yeah, you ovulated. There's a corpus luteum there. Your progesterone level is high, and that means you're going to get a period sometime in the next week or something. We can usually see that by the hormone levels. But in people who chronically don't ovulate, the uterus and the ovaries are all hanging out, feeling like they're at the very beginning of the cycle. So there's some people that will test and we see, well, you haven't had a period for 36 days, but there's nothing going on. So you can just go ahead and start. So easy enough to tell by doing your baseline. So that's probably going to be what we're going to recommend for you. Nicole says, do you change the protocols for someone with, it looks like MCAS, and I am not sure what MCAS is. So I don't know how to answer that question. Lucretia says, I started all of my supplements and carnivore yesterday. When should I do an egg retrieval? So the sweet spot for the supplements is generally about 2 to 3 months to have the best effect on egg quality, but you can move forward, my friend, whenever you are ready, because if you started that stuff, then hopefully we are ready for you as well. That we told you to do it. So whenever you're ready, you just let us know. And that's how the process begins. You get a period and you tell us. Gosh, the time is slipping right by. It's 56 minutes after the hour. We've got time for just a few more questions here. Let's see what we can get. S. Alvarez says, my first transfer failed. I go in tomorrow for my ultrasound and blood work to see if I'm ready for my next FET. If everything looks good, when should I expect to have my next transfer? I would go ahead and start it right now, as long as you are both emotionally, financially, and logistically ready to move ahead. There is no reason that you can't jump right in to another transfer cycle. Now, we know that doing retrievals back to back is beneficial, that with each stacked cycle, we're going to get progressively better and better results. The same does not necessarily hold true for embryo transfer. You can take a break. That won't hurt you. You can go right into it, and that won't hurt you either. So it's kind of 6 of one, half dozen of the other. So that's why I fall back on emotionally ready, financially ready, and logistically ready. Okay, so best of luck to you, S. Alvarez. My Sudran says my wife's AMH is low. Before the FET, do you recommend for her to do a Receptiva test? So Receptiva is the test for the non-invasive test for endometriosis. You may have heard me say that in the past we had to do surgery in order really to truly diagnose your endometriosis. Now we can do that through simply performing an endometrial biopsy. The endometrial biopsy looks for a marker in the uterine lining called BCL6. I have not seen data that says there's a reason not to. So especially if you are limited in the number of embryos that you have, Sudran, then every one of them is precious, and so we want to maximize the odds for every one of them. I think it's not a bad idea to go ahead and do that Receptiva test. You don't have to come in to our office for it. It can be done at your own doctor. You can look at receptivadx.com to learn a little bit more. They also have a whole network of places that you can go if your own doctor's office is not comfortable doing it. Put in where you live and it'll show you places that you can go. Blue Duckling 18. I love that handle. That is a good one. Gosh, we're going to run out of time before I had a chance to answer a question about constipation. Oh man, that's everybody's favorite topic. Why do I get constipated when I'm doing all this fertility treatments? And the answer is hormones. Hormones affect everything. They speed up your gastrointestinal tract and they slow it down. They affect the blood supply going to the bowel, just like they affect the blood supply going to the uterus and the ovaries. And so that's really the reason. If you do an egg retrieval and you get some pain medicine, well, pain medicine, even done through the IV under anesthesia, can also slow the bowels down. But there are some easy solutions to that. Maybe we'll save that one for next time. How about that? Is CoQ10 a necessity? Does it aid in IVF success? This will be my last question for the day. Yes, it does. CoQ10 is probably the most important supplement that you can take for egg quality. Hi, Mrs. Vince. Nice to see you as well. Well, folks, it is top of the hour. Boy, we've been here for the whole hour. It has just flown right by, as it always does. We're back every Tuesday, though, so please join me next week, won't you? Because I am Fink and you are friends, and there is nowhere else that you are supposed to be on a Tuesday evening but Fertility with Fink and Friends. Every day forward with kindness. Please spread kindness. This world is not a kind enough place right now, and God knows a kind word, a kind look, a touch, anything special to another human being is enough to change someone's life. And don't forget that. You have that power. Every step with love and each day with hope, knowing that tomorrow brings a whole new sunrise. Yesterday is only a memory, and whatever we have can happen to us. The future is at our feet. Hope for tomorrow. This is not the story of your life. This is just one chapter. And what are we doing here? We are here to rewrite it. So until next week, God bless and thanks so much for being here. I'm Dr. Randy Fink in Colorado Springs. Good night.